Good evening, everyone. Welcome. I'm Dr. Nitin Abhyankar, welcoming you to a wonderful new webinar in CCI, our Thursday meetings. And we have an obituary, so sad, but we have to do that. Can we? We recently, on 4th of July, lost Padma Shri Dr. M.C. Dawar. He is the father of our own Dr. Rishi Dawar, and we feel utmost grief while announcing this sad demise. And we'll have a 10 minutes, 10-second silence. Let's move on. And the show has to go on, so one way or the other. Today, we have a very, very interesting topic to talk about. And it's very unusual. Very frankly, when I first looked at it, I said, how am I going to moderate this where I know very little? And so asking questions and learning is the only objective was my first motto when I said yes. But I'm sure we have a lot of help here and expert help here. And I won't name the entire panel right now, but I'll introduce the first person who's going to give us a talk, who is Dr. Beauty Biswas. Hi, Dr. Beauty. Welcome to this webinar. And we will be having her talk on the basic introduction to the topic and the basics of drug-induced lung injury. We are very specific about this because we are not discussing drug-induced anything else. Drug-induced hepatitis is not on the discussion cards here. So, can I have Dr. Beauty is from Kolkata? Is that right? Sorry, if I'm not. Yeah, that's right. So, with that, over to the technical team for the talk, and then we will have the panel discussion.
Thank you, Dr. Nitin, for this lovely introduction. I am Dr. Beauty Biswas, now going to present a talk on drug-induced lung disease, patterns, perils, and pragmatic treatment options. So, what is drug-induced lung disease? Basically, it constitutes a significant heterogeneous group of adverse drug reactions that occur after exposure to various medications. To date, more than 500 drugs have been associated with the emergence of drug-induced lung disease, a number that rises every year, particularly with the increasing use of antineoplastic drugs, immune checkpoint inhibitors, antiarrhythmics, antibiotics, and disease-modifying antirheumatic drugs. So, what are the main risk factors? And these are advanced age, renal dysfunction, dose-dependent toxicity, genetic predisposition, previous radiotherapy, pre-existing ILD, exposure to high FiO2, concurrent administration of pneumotoxic drugs, poor performance status or advanced lung cancer, smoking or history of COPD. So now come to the key mechanisms. The three mechanisms have been described so far in studies. First, direct toxicity. Some drugs can directly damage lung cells, that is pneumocytes and alveolar capillary endothelium, or induce oxidative stress leading to cell injury and inflammation. Immune-mediated lung injury is the second one. When drugs can act as haptens, triggering immune responses that lead to inflammation, pneumonitis, and potentially fibrosis. And third one is systemic cytokine release. Some drugs can cause the release of cytokines leading to widespread inflammation, capillary leakage, and pulmonary edema. So this is the pictorial representation of my previous slides. Actually, here three mechanisms are going on, which you can see. Now come to the offending agents, most common being the chemotherapeutic agents like methotrexate, bleomycin, etc. Others are immune suppressive agents like sirolimus, leflunomide, etc. Immune therapy agents, immune checkpoint inhibitors, that is like nivolumab, pembrolizumab, etc. Monoclonal antibody such as rituximab, trastuzumab. DMRDs like adalimumab. Cardiovascular agents like amiodarone. Antibiotics like daptomycin, nitrofurantoin, etc. Anti-inflammatory agents like gold. Non-medical drug use like methylphenidate. Anti-seizure medications like phenidone. So now, what are the main patterns of pulmonary toxicity and the potential treatments causing the toxicity? Like acute or subacute ILD caused by various drugs, among them TNF alpha agonist, antagonist, immune checkpoint inhibitors. These are the mentioned one. Others are organizing pneumonia caused by amiodarone, antineoplastic agents, sulfasalazine, rituximab, minocycline, etc. Pulmonary fibrosis caused by chemotherapeutic agents like bleomycin, cyclophosphamide, etc. Eosinophilic pneumonia can be caused by antibiotics such as minocycline, nitrofurantoin, and other agents. Sarcoid-like reaction can be caused by pirfenidone, heart, uh, immune checkpoint inhibitors, etc. Non-cardiogenic pulmonary edema. Offending agents are nitrofurantoin, aspirin, chemotherapeutic agents, etc. Pleuroparenchymal fibroelastosis can be caused by cyclophosphamide, alkylating agents, daptomycin, etc. Hypersensitivity pneumonitis, and the agents are methotrexate, cannabis, irinotecan, etc. Airways disease can be caused by immune checkpoint inhibitors also. And pulmonary alveolar proteinosis can be caused by various chemotherapeutic agents, cyclosporine, etc. Some, like as ACE inhibitor, also cause cough and angioedema. And bronchospasm and anaphylaxis, usual side effect of beta blocker, all of we know. Pulmonary hypertension can be a result of ingestion of cocaine, fenfluramine, etc. And pleural effusion, which is drug induced, and these drugs can be dasatinib, phenytoin, hydralazine, etc. So the list is much bigger actually. So now come to the epidemiology. The reported incidence of drug-induced lung disease varies widely, but a recent systematic analysis reported an incidence of drug-induced interstitial lung disease in 0.4 to 1.24 per 1 lakh cases per year. Moreover, approximately 3 to 5% of all cases of drug-induced diffuse ILD seen. In studies, patients with non-small cell lung cancer have overall incidence of drug-induced lung disease around 1.4 to 5.8%. And in patients with autoimmune diseases, especially rheumatoid arthritis, the prevalence is 0.3 to 11% in those treated with methotrexate and 0.5 to 3% in those treated with anti-TNF agents. So, early diagnosis basically is very important and prompt clinical management are essential. Though DILD is difficult to distinguish clinically from other causes of diffuse pulmonary opacities, radiological findings play a key role, basically the HRCT thorax. But it helpful in categorizing the lung injury, does not confidently predict the histopathological pattern. Additionally, lab findings along with the clinical and medication history are complementary to the diagnosis of drug-induced lung disease. Recently, Flesner Society recommended the following diagnostic criteria for DILD. First, newly identified pulmonary opacities. Second, temporal relationship of presentation with the initiation of medications. And third is the exclusion of other possible causes. So, bronchoscopy and bronchoalveolar lavage basically done to exclude infections, lung malignancies, alveolar hemorrhage, and pulmonary alveolar proteinosis. And common cellular profile is seen in bronchoalveolar lavage is lymphocytosis. Lung biopsy is done very rarely, but because histopathological patterns usually not specific for DILD. Hence, These two should be done depending on the clinical situation and benefit risk analysis. So now one important thing, grades of pneumonitis, because the prognosis is depend much more on it. So 5 grades are there. Mild means asymptomatic when only radiographic changes exist. Moderate, that is symptomatic, not interfering with the activities of daily living. Severe, when involvement is more than 50% of lung and requiring hospitalization. Life-threatening, respiratory involvement when ventilator support is required, and fatal can be occurred, which is the last stage. So severe pneumonitis or from grade 3 onwards can occur in 2 to 9% patients, with higher incidence in individuals who have pre-existing lung conditions and are using more than one drug simultaneously, often resulting in mortality rates as high as 36%. Although clinical conditions of the patient may vary from mild symptoms to life-threatening, but usually they presented with milder one. Shortness of breath, coughing, wheezing, chest pain can be occur in patients with drug-induced lung disease. So this is the graphical representation of the CT involvement in drug-induced lung disease. I'll describe it later. And just remember the names: organizing pneumonia pattern, non-specific interstitial pneumonia pattern, hypersensitivity pneumonitis pattern, diffuse alveolar damage, simple pulmonary eosinophilia pattern. And other 3 entities are sarcoid-like granulomatosis, pneumonitis, flare-up, and radiation recall. So this is the organizing pneumonia pattern, where you can see peripherally placed pneumonia consolidating lesions in both lung. This is the non-specific interstitial pneumonia pattern. Here you can see the basal sparing along with patchy areas of GGOs and consolidation along with traction bronchiectasis and reticulation. This is a hypersensitivity pneumonitis pattern, and this in this you can see that diffuse areas of GGOs filling both lung. This is the diffuse alveolar damage pattern, and in this pattern you can see that the lung affected badly bilaterally and more extensively. This is the eosinophilic pneumonia pattern. Basically here we can see patchy areas of GGOs or consolidation, mostly peripherally placed, and these are fleeting in nature usually. This is one important slide in which you can see transfusion related lung injury. This is also considered as drug-induced lung disease. Here you can see that the involvement is more diffuse and it looks like only GGOs are present. In this slide, in the CT scan, you can see the sarcoid-like granulomatosis picture with involvement of the mediastinal lymph node. And this slide shows pneumonitis flare-up with patchy infiltrates and nodules and patchy areas of consolidations or GGOs in the peripheral part. So now come to the one important thing, that is radiation recall. This is basically an acute inflammatory condition that occurs in a previously irradiated field after exposure to a provocative agent and is observed in many organs and systems, including lungs. In the past, reports of radiation recall pneumonitis was common with the treatment with taxane-based chemotherapy agents and gemcitabine. Though radiation recall pneumonitis due to immune checkpoint inhibitor therapy has been reported recently with increasing frequency. Shibaki et al. Recently reported that the average time between development of radiation recall pneumonitis and exposure of radiotherapy is around 2 years, and the frequency around 4.5% in patients who had previously received radiotherapy and were treated with tyrosine kinase inhibitors. Although the etiopathogenesis is unclear, and awareness of this condition is essential to avoid the misdiagnosis of underlying disease progression. So now come to this flowchart. So basically the major entity is the interstitial involvement. So to manage these patients, we need to inquire about their respiratory symptoms. then the radiological involvement through chest X-ray or CT scan. We need to inquire about their history of exposure to the drug. Specifically, the timing and the duration is very important so that we can classify them. Then we need to exclude the other causes of ILD, such as infection, heart failure, and underlying disease exacerbation. And the mainstay of treatment is drug discontinuation, and we need to consider steroids. But there are 4 grades of involvement. If the patient belongs to grade 1, that is asymptomatic and few chest CT abnormalities, then you can close follow-up, or low dose steroid you can start. Grade 2, when the patient is symptomatic or moderate chest CT abnormalities seen, then you can start the steroids at 1 to 2 mg per kg per day. If the patient presented with severe symptoms where hospitalization is mandatory, then you need to consider higher dose of steroid. And if he developed life-threatening respiratory compromise along with the mechanical ventilation, then we need to consider the pulse therapy. The steroid tapering should be conducted very slowly and carefully over the course of at least 6 weeks, given that relapses of pneumonitis have been reported during the weaning period. Persistent changes on chest CT can be useful to guide steroid tapering over time. In other cases of involvement due to drug exposure, we need to discontinue the medication first because it is the most crucial step to prevent further damage and allow the lungs to heal potentially. Other supportive cares are oxygen therapy. It helps to improve breathing and oxygen levels in the blood. Pulmonary rehabilitation. It helps to improve the lung function and quality of life, especially those with chronic lung conditions. Smoking cessation is equally important. That can worsen lung damage. And treating infection is very much important because it can help prevent further complications. Among the pharmacological interventions, steroid here also the mainstay of treatment, and you can consider other immunosuppression if patient is not responding to steroid. And if patient develops severe cases of irreversible fibrosis, then lung transplantation may be considered. Besides this, we need to monitor them regularly with proper lung function and overall health status. We need to repeat the chest X-ray and CT scan wherever is applicable for assessing the extent and pattern of lung involvement and recovery both. So now come to the prognosis. Some factors influencing the prognosis. These are the causative drug itself, the radiological pattern, that is mild or advanced, severity of the lung damage, individual factors like if the patient is young, then the chances of recovery will be more. If the overall health condition is good, then also the recovery or prognosis is very much good. If he has no comorbidities, then the prognosis is very good. While drug-induced lung disease can be fatal, mortality rates vary. Some studies show a 25 to 30% mortality rate in patients with drug-induced lung disease, while others report higher rates in severe cases. And regarding recovery, some patients recover fully after stopping the offending drug and receiving appropriate treatment such as steroids, and some develop chronic. In that case, they require long-term management and potentially leading to respiratory complications. These are my references. Thank you.
Yeah. Wonderful talk, Dr. Beauty. Thank you. Thank you for being with us. Dr. Beauty Biswas is already being introduced, and I think you have heard her, and I think you have understood the importance of drug-induced lung injury. Let me reintroduce the panel all over again. Dr. Tridib, sir, Dr. Tridib Chakravarti from Mumbai in Bombay Hospital. He's one of the senior most pulmonologist and one of the most respected ones, and more importantly, one of the most avid attender of almost all the meetings I have ever come across. So he is always learning, and surely he is worthy of teaching a lot more than he does. So I mean, we are blessed to have you, sir. Um, the pharmacologist on the team is going to be Dr. Subhankar, and he's from Rourkela, and he's again a great addition, value addition to this whole program, because we are all clinicians, and the pharmacologist perspective matters a lot. Dr. Mm, Vinay Kumar Kancharla from Vijayawada is our another panelist, Dr. Sorry, Dr. Anil Kumar Kancharla from, sorry about that. So, welcome to this panel, and we are great to have you. So, if you really look at north, south, east, west, we are probably covering everything. And I think this is going to be a very exciting panel discussion uh, based on what Beauty is already beautifully elaborated. Let me ask the first question, which is open to all of you. And I don't know whether everybody has a story or not. If nobody has a story, I may have one story, but one way or the other, I'm hoping somebody will come up, at least one, that where a timely recognition of a drug induced lung injury made a positive impact on a patient's life. Anybody?
So, Nitin, I have only
Yes.
one, and
Sure.
I assume that is the cause. So, this was many years ago. An elderly lady, female lady, and diabetic, not under control, and she used to get repeated urinary infections. So she went to some family doctor. Then finally the urine culture was done, and some sort of quinolone or something was given for the urinary infection, which she recovered. Pus cells went down, everything, but repeat urine showed some few pus cells, 10 pulses, something like that. So in that whole list, nitrofurantoin was also there. So he told
Okay.
him that, "Bhai, yeah, you continue. Like, you stop all this nitrofurantoin, like, chalu rakho.
Not indefinite, forever.
Sterilizing type, I don't know. I guess everybody may be having this experience. I don't know. But oh, chalu rakha, and again she felt better. Then, as usual, diabetes not under control, and not, local hygiene was not there probably. So again she used to get, so without asking, she used to take this short 10 days of history of nitrofurantoin. There were no respiratory complaints. Huh? This way it continued for about maybe 1 2 months. Then these non-specific respiratory complaints which Beauty mentioned of cough and no fever, cough and little breathlessness started coming up. The X-ray and then a CT scan was done. That CT scan did show that a reticular nodule pattern, something like an NSIP pattern. I mean, roughly, not exactly OP and NP pattern. So as usual, antibiotics चालू हो गया. Sputum was tried for A, B because diabetic नहीं आया. So after 2 3 rounds of antibiotics, चल भाई टीबी होने का चांस है, डायबिटीज है, इसको एकेटीबी चालू कर देते हैं. There was,
Oh,
तो उसको थोड़ा एकेटीबी चालू हो गया. But as usual, there was no real any benefit. It was continuing. So somehow this patient added up to me. This was by this time almost maybe 2 months were over. So when I saw the scan and then I just went through all the files, I saw this murinated. So let me be very, it came in my mind that this could be it. There was no fever and that CRP and all were not very high. And there was no sputum. So I said, now, 2 3 महीना हो गया, अपन एक scan repeat करते हैं. And I said that you have to go to Bhavi Chankaria, please, because he's the absolute best. So I convinced them and sent him to Bhavin. And their shadows had increased. And I had a long discussion with Bhavin, which is, I think, in these cases, talk is the way to diagnose. This is
absolutely.
not so easy to diagnose. This today's topic is entirely on multidiscipline. So here multidisciplinary was with me and Bhavin only. And we both agreed that this could be nitrofurantoin. तो पहले तो उसको बोलो बंद करने को, and थोड़ा 2 weeks steroid दिया, where I involved a diabetologist. बोला भाई, you have to just, I'm giving little steroid 0.5 mg. जरा इसका sugar बढ़ सकता है. You just manage the diabetes part. And to my very and everybody's happiness, within say 3 to 4 weeks, she improved. She started improving, and I think 4 or 6 weeks later, we repeated a scan, and that scan actually completely improved. So that's the only one case which I have of this.
Wonderful. Beautiful case, sir. Nitrofuranate and Dr. Anil Kumar, sir.
Yeah, sir. I would
Yeah.
like to share an anecdote. I had one 60-year-old businessman. Like I met him in a function one day, and he was like saying, Anil, I have a continuous cough since more than 2 years. This was more than 2 years. He had a continuous cough. And in the meanwhile, he had met many doctors. Basically, he never met a pulmonologist for this. He used to go to their general family physicians and all. He went to a cardiologist for that. And he was still continuing medicines. Later, when he told me and I took the entire history, it was simple. Then I asked him, what are your hypertensive medications? He said that it was the ramipril. That's the ACE inhibitor. That was quite simple that the ACE inhibitor was causing that cough. And the cough was predominant more in the nights. Then I said, Uncle, please stop this drug and come back to me in 2 weeks of time. He stopped it, and you take it within 2 weeks, his entire cough got settled. Now,
Absolutely.
whenever there is any issue, now he has stopped going to other physicians and cardiologists. Any issues that he has started coming back to me again and again. That's one thing I can share.
I have a story, sir.
Wonderfully good. Yes.
I have a story.
Yes, Dr. Nitin.
One patient, around 45 years old male, who was diagnosed with CML 1 year back almost, and started on dasatinib. He developed recurrent episodes of pleural effusion after 3 to 4 months of starting of the drug. But he is going to very other GP, basically general physicians, and they are just aspirating the fluid and send him back. So no diagnosis has been made. So finally, after 3 to 4 times of aspiration, he came to us, and we did the thoracoscopy also, which revealed that mixed inflammation basically. Then we again going back to the history and asking about the detail of the exposure, etc. We also talked with the oncologist also, and tell them our suspicion and tell them to modify the dasatinib if possible to avoid, if not to modify the dosage, and they reduce the dosage then. And finally, the patient is just coming to my OPD just 3 to 4 days back, and it is almost 8 months when he's absolutely fine with no occurrence of pleural effusion.
Amazing. I mean, gefitinib, I mean, we've been witnessing that, and I think we almost have it by heart now. In fact, the kind of maps which are there, I can't even pronounce them properly. Gefitinib, I can, because I was involved in the first study, and it's not pulmonary in the true sense, but one of my patients who was on warfarin, we were maintaining the INR between 2 to 2.5 beautifully for years. And he went on to gefitinib because of his cancer. And then suddenly the INR was 16. And we were not really able to make sense into the whole thing. And, finally it came back to the idea, okay, fine. There was the only new thing which had happened was gefitinib. And then sort of we took care of it and things fell in place. We did not stop gefitinib, we stopped warfarin because it was not needed in this case, and in a very small dose was enough, basically. Any other story from anybody, please? I mean, though mine was not a purely lung one.
Me, sir.
Yeah, please. Dr. Subhankar.
Sir, am I audible, sir?
Yes, absolutely. Please go on.
Sir, it was my residency time when I was in RIMS Ranchi. What happened actually, there was a post-MI patient admitted on cardiology unit. Suddenly, after having some abnormal ECG findings, he was started with amiodarone. And it was after 1 to 2 months, suddenly, when he returned, everything was okay. And our cardiologist, sir, was very much curious about the toxic effects of amiodarone. So regular CT scan was done in every 10 to 15 days because he has seen
Oh,
amiodarone-induced fibrosis.
I
Now,
think you are in a you're living in a utopian world, very frankly. हमारे cardiologist हम ये डर उनको तो भगवान समझते हैं. They will never do a CT scan.
no, he was very much suspicious about it, about this drug, sir. And what usually happened that
But
reactivation of
I think it's to be complimented. Absolutely great.
yes, sir, and there was also reactivation of pulmonary couch in this patient, and he was started with isoniazid, rifampicin, pyrazinamide, and all. What happened, sir? The lung was almost clear, and there was no evidence of any amiodarone-induced fibrosis or any type of assault. But just after introducing ATT, within 10 to 15 days, there was appearance of patches in both the lungs. And
Oh,
after reducing the dose of amiodarone and omitting rifampicin for 1 week, the patches were clear.
wow.
And we reported the case that may be because the other histopathological investigation and bronchoscopy, all these things was not possible in this fragile patient, sir. But we assume that the rifampicin induced enzyme induction may have led to active metabolite formation of amiodarone, which was responsible for this assault.
Yeah. So it's almost like a subacute amiodarone
Yes, sir.
lung. Yeah,
And it
wonderful.
responded, sir.
Absolutely. Wonderfully, beautifully put. I mean, so I think we have covered almost everybody. I think everybody has shared at least one experience of drug-induced lung or one way or the other injury. So I think uh, let me come to, I mean, Subhankar sir again, and we'll ask you about could you blame a particular drug for a particular drug-induced lung injury, and how do you go about it? I mean, is there a methodology?
Sir, like microorganisms, they produce pathogenesis in different way. Drugs also have their pathogenesis in different ways. We have two type of adverse drug reactions. One is type A, augmented reaction, and there is type 2, that is bizarre, type B or bizarre reaction. Augmented reactions are associated with pharmacological mechanism of the drug. And like it is, few examples we have, and in all the cases, you the clinicians, sir, today so much aware that type A adverse drug reaction आज की डेट में बहुत कम है. Like AC inhibitors induce cough. We are getting a patient with cough. We are shifting it to AT1 antagonist. Okay. We are giving some beta blocker to some person. We used to choose selective beta blocker. We are not going for non-selective beta blocker. Patient has asthma, will precipitate. We are very much aware. Or there is aspirin sensitive asthma, sir. In aspirin sensitive asthma, if the patient is in a, you can say like post MI patient and we have to continue aspirin, if there is mandatory, there is mild aspirin induced lung symptoms, we can continue. But if there is formation of polyp and all these things, then we have to discontinue aspirin. So we are all aware with type A adverse drug reactions. Unless and until we don't take any previous history, we can make mistakes. Like one mistake I have seen with a clinician that
Yeah.
a 26-year-old female was suffering from migraine, and she was given Inderal, that is propranolol, without taking proper history that she was asthmatic, and it precipitated attack within 7 to 10 days. So this type of mistakes can only be done if we are not aware with मैंने we हम लोग भूल जाते हैं हिस्ट्री लेना या कुछ चीज, तभी टाइप ए एडवर्स ड्रग रिएक्शन आ सकते हैं. But the very dangerous challenge is type B adverse drug reaction, and particularly in lung injuries. I will use the word injury when this is reversible, and will use the word sir assault when it is irreversible. Now, sir, what happens, sir?
That's a very interesting thought. Is this validated? I mean, or this is your thinking?
No, sir. I'm speaking with all the validation, sir. Sir, in type B lung injuries, sir.
No, the assault and injury are these terms sorted out completely, or
I have just completed type A adverse drug reactions, and the and the mechanisms of these assaults are related with the pharmacological action of the drug. But type B reactions are not related with the pharmacological actions of the drug.
They
And
could
this
be
is a great,
what else? Yes.
yes, and they are great challenges. Why? Because clinical features, chest X-ray, CT scan, and histopathology. Two standard deviations सब अलग अलग होते जाते हैं and very difficult to get in a inference after getting all the findings. Number one. Number two, a single offender with a single pathological phenomenon causing a single outcome is rare, sir. Never possible.
Absolutely.
And when we are giving chemotherapy, three offenders are there, and it is very difficult to choose one from 2 to 3. Second. Thirdly, what I have accumulated some points regarding all my last 10 to 15 years, that, sir, definitive diagnosis through histopathology is not also possible. Ethical issues are there.
Yeah.
So after having all these things, still there are some mechanisms through which they can make assault. Number one, that is the direct cytotoxicity. The drugs in a huge amount getting concentrated to pneumocyte or bronchial epithelium rather than other body tissues. This is one mechanism. And particularly in this, we know bleomycin, least amount of hydrolysis present in lung and skin. That's why these are the two preferred sites for deposition of bleomycin and causing assault. Lung is one of them. Then the second thing is biotransformation. Metabolic product is more dangerous than the primary substance, that is amiodarone, which is mostly responsible. After that, sir, other mechanisms of lung injury, we have hypersensitivity reactions. Hello, am I audible, sir?
Yeah, I think there's something wrong with your network, or I'm not sure. Yeah. Please go on. Let's listen to
Am I audible, na, sir? Hello, sir, am I audible?
Yes, we can hear you. Dr. Subhankar, we can hear you.
Okay, sir. Okay. Just pardon me, sir.
We can hear you.
Okay, sir. Next, sir, I just want to say immune-mediated injuries. In immune-mediated injuries, like other drugs, sir, in our regular practice, हम लोग AMC में जो report करते हैं, sir, उसमें maximum type 1, type 2 and type 3 hypersensitivity reactions आते हैं. Type 4 hypersensitivity reactions are comparatively less. But in case of lung injuries, type 4 hypersensitivity reactions are maximum. And maximally they are T-cell mediated lung injuries. And in these injuries, many things can happen, like the drug may act like a hapten and induce hypersensitivity reaction. Second, there may be defect in immune tolerance mechanism, that is self getting non-self. Why? Because after attachment of the drug to particular cell, the body may recognize the cell as non-self and send T cells to kill or destroy the cells. So these are the mechanisms of hypersensitivity reactions. And of course, there is hypersensitivity pneumonitis and the type 3 reaction, which is, I can say, the most specific type 3 reaction we get in our regular ADR reporting. It is drug-induced SLE, that is DLE. The acetylated substances, the drugs getting metabolism by acetylations, they are responsible for this type 3 hypersensitivity reaction, sulfonamides and the hydralazine, the most common culprit. So this is another mechanism for lung injury. Third one, this free radical generated injuries. In this, two main culprits, one is bleomycin, and the second one, Honorable Tridib sir has mentioned nitrofurantoin. I have reported 7 to 8 cases of nitrofurantoin induced different organ system assault. Arrhythmia से लेके, psychosis से लेके, lung injury से लेके, total 7 to 8 cases we have reported. And actually culture sensitivity reaction देखे बिना maximum periphery के doctors फीमेल्स को इस ड्रग से कम महीना पे महीना चला देते हैं. दिस इज द मोस्ट कॉमन रीजन.
Yeah.
And lastly, not the least, I will conclude it, sir, because I am taking time, I know. And one most important finding, we know that bleomycin gets metabolized by hydrolase enzyme. If there is any defect in hydrolase, we cannot even imagine what can happen in first dose. One such incidence that was reported from SSKM Kolkata, that testicular cancer was there and bleomycin was administered in the first dose. In the first dose, there was alveolar edema and diffuse lung damage in the first cycle, you can say. Generally, we see that in bleomycin therapy, the assault starts from 2 to 3, after 2 to 3 cycles, but it developed in the first cycle. And after genetic testing in biochemistry department, they sent the sample, I think Tata or anywhere something. It was confirmed that there was single nucleotide polymorphism in bleomycin hydrolase. That's why it was completely absent in lung and was responsible for immediate assault. So there are many more mechanisms, but there are many more panelists. I will not waste my time. I'm concluding here.
Wonderful. Beautifully put, Dr. Subhankar. Let me come to Dr. Tridib, sir. Let's go back to, he has taken us to the heaven, and let's come back to the ground.
It was a very nice,
beautifully encapsulated, topic on almost like a lecture on drug-induced lung injury. But let's come back to now. Let's see very common things like acute. When we are talking of anything related to drugs, we say adverse event, serious adverse event, drug-induced adverse event, and a drug-induced lung injury. So, could you talk a little about the definitions?
Yeah. So,
and then I also want you to talk a little about acute, subacute, chronic drug-induced lung injury. So, both questions you could take.
Okay, done. So, let's start with definitions. More or less, which is agreed upon. So, a drug-induced lung injury is because it results in the injury of to the lung. So when you talk of lung, you talk of the entire structure of the lung, the parenchyma, the interstitium, the pleura, and the vasculature, all the compartments of lung. It's not just one part. As Dr. Beauty said, that one pleural effusion is there. So that is also part of the lung. So the entire, any structure of the lung, one or more, which is affected by a drug which is not necessarily just over the counter, but even supplemental drugs, even herbal medicine. This is very important. India may be a lot of Ayurvedic medicines. We don't even know what they contain. So those drugs can also affect the lung, and also illegal narcotics like cocaine and all that. This, when they affect that injury is also considered as a drug.
Even vaping.
Yeah, so vaping, yes. So all those things will affect the lung. They are affecting they called drug-induced lung injury. And of course, here it is important to know that the patient has taken the drug. The temporal sort of progress is to be, he has taken the drug, and then over a period of time he has developed. That is essential. That history is like I did here. In my case, I just saw that neuroparenchyma going on. Here, somebody, the doctor said that he has seen enalapril going on there. So, or ACE inhibitor. So then that was the reason why he thought that, okay, the cough could be because of that. So that is very essential. Whereas an adverse reaction is any untoward or sort of an offending thing which happened to any drug, and that is not restricted to respiratory system. So you can have, say, vomiting because of steroids or NSA. You can have a skin rash. So that's called an adverse effect or side effect. But a serious adverse effect is something which will cause either permanent disability, it will cause death, hospitalization, or congenital anomaly. And this is an ideal, actually, if it is that, it is actually notifiable. You are supposed to notify it. There is some procedure to notify. I am not exactly aware of how to do it, but you have to actually notify that. So DLID is a kind of an adverse reaction which is restricted to the lung.
Only
So
the
that is the type of thing which I would like to tell.
absolutely.
Achha, regarding that second part of the question is acute and subacute and chronic.
Acute and chronic, yes.
So now here, actually there is no clear cut margins here. They say that after the drug use, average is within the 2 to 3 months it happens. But it can happen in a few days. Like in this case, which Dr. Subhankar mentioned, that the patient not given bleomycin first dose and he landed up with pulmonary edema and all that. So,
Absolutely.
you can.
Are we
Sorry.
on mute?
Yeah, I just got muted. So acute reactions can happen like aspirin. Now, one of the things which can happen in aspirin, if the patient is an aspirin sensitive, that he can get a fairly acute attack of an asthma. Or one of these old beta blockers, within few days or weeks, he may get an acute attack of that. So that is one place. Sometimes nitrofurantoin or sulfonamides can have acute to subacute. Then pulmonary edema can happen. So it can be a cardiogenic type or a non-cardiogenic. These are more or less acute stage. So contrast media, excessive fluids, this will lead to acute pulmonary edema. But non-cardiogenic pulmonary edema can happen because of giving of IV and agonists or these vaping or your this drugs they put IV, cocaine and I don't know what they put. All those guys, they have the acute, fairly acute. But by and large, all these other drugs, most of them average would be around 3 months is the time at subacute to chronic stage. But it is essential that we must know that the drug is on and something new comes up, as Dr. Beauty mentioned, new opacities come up. We should try and then think of this. That's the whole purpose of today's meeting, I think.
Absolutely. I think
Thank you.
one thing I think which comes across is that some patients get it, not everybody gets it. And I think I'm going to come to Dr. Anil Kumar Kancharla for this question. Is what are those risk factors which make some people more prone to getting a drug-induced lung injury as compared to others?
Thank you, Nitin sir. And first of all, Guru Purnima ki shubhkamnaएं सब लोगों को, or to all the elders and all the juniors and all the teachers in the group, sir. As you mentioned, sir, so drug-induced lung injury, or let us call it as drug-induced pulmonary toxicity, there are some simple risk factors which we can look into. And let us be very simple in this. The most important of them all is the age. So the thing is, both older adults and even the young children, both of them are more susceptible on either part of the spectrum. In generally, older adults, what happens is there is a decreased organ function, either it's renal or maybe an altered liver function, hepatic function, which can affect the drug metabolism and clearance. So this leads to higher concentrations in the body. So age is one risk factor, I would say. And presence of any other pre-existing lung disease like COPD or some interstitial lung diseases or a previous history of a thoracic surgery. All these things are patient-specific risk factors which increase the risk of the drug-induced lung injury. When it comes to the other contributing factors, I would say smoking. This increases overall lung inflammation, and the susceptibility to the DLI increases with smoking. Radiation therapy, exposure to the radiation, patients are more prone to damage lung tissue and more prone to the DLI. Sometimes renal dysfunction, when there is an impaired kidney function also, it can lead to an elevated drug level. And as you mentioned, some people are more prone. That's the genetic predisposition, and it's very tough to say which group is more prone to drug-induced lung injury. Sometimes certain drug combinations, are there might be a synergistic effect with some drug combinations like a bleomycin or cisplatin, sometimes gemcitabine with paclitaxel. They also can increase the causes of a lung injury. And if it comes to the medicinal part, if you see, high doses or prolonged exposures, that is the dose and duration of drug, both can play an important role in the lung injury, and as well as ethnicity. If you look into that, some ethnic groups may have a higher rates of drug-induced lung injury, as well as radiation exposure I mentioned to you before. Occupational exposure is important, and sometimes people who are on high volumes of oxygen, like say high FiO2 of oxygen, they're using continuously, are also prone to drug-induced lung injury.
Wonderfully put, beautifully encapsulated. Greatly done, sir. I'll come to Dr. Beauty. We have left you after your lecture talk for a long time. So, can one drug cause multiple types of clinical diseases, and the other way, vice versa? Is it possible that multiple drugs can be having similar kind of drug related lung damage? So, is it possible? If you could give examples, it will be even better.
Yes, many drugs can manifest in different pulmonary syndromes. As far as I remember, amiodarone, which can cause the organizing pneumonia pattern, interstitial pneumonitis, diffuse alveolar hemorrhage, ARDS pattern. So multiple patterns can be seen with amiodarone. Besides like that, nitrofurantoin, that also cause interstitial involvement, especially hypersensitivity pneumonitis pattern, organizing pneumonia pattern. So there's another important drug, methotrexate. This is also can cause subacute HP pattern or organizing pneumonia pattern, and in long term it can produce fibrosis also.
Yeah, absolutely. Yeah, and
Besides,
the methotrexate lung is like an enigma to most of us, including the rheumatologists, including the clinicians. I mean,
like
yeah.
Besides that, many drugs may presented with similar types of involvement. That's why CT features are not so unique for any specific types. Like interstitial pneumonitis can happen with any of them, which I have already described, like amiodarone, bleomycin, methotrexate, nitrofurantoin, or even non-cardiogenic pulmonary edema that can be caused by methotrexate also, even salicylate also. And so mixing is there, sir. So no pattern is specific for any specific drug-induced lung disease through which we can definitely diagnose this.
Yeah. So, I mean, the entire clinical story is not always going to be conclusive. We have to be having something in addition, something at least the minimum is the radiology, and then sometimes we have to move it. We'll move on. And Tridib sir, this is a question for you. Is it possible that some drugs, I mean, I think Dr. Anil Kumar made a reference to it. Some particular ethnicities are likely to be more damaged by a particular drug.
Yeah. So
Yeah.
ethnicity is definite. Ethnicity is a definite. Even though there may be a lot of environmental factors, socio-economic factors which may alter, but definitely certain like Japanese. Now this has been seen in Japanese people. That is Jeffersinib, leflunomide. These kind of drugs, they have got much more higher levels of uh, chances of developing interstitial pneumonitis or interstitial fibrosis. Similarly, also they have it is. I saw a literature of saying that interstitial pneumonia rapidly progresses in myopathic dermatomyositis. Dermatomyositis without muscle involvement. There also in the Japanese, it has been found that there is more. I actually found the literature of this, and the various. As I think he referred to, Dr. Subhankar mentioned this. Some of this is because of this various cytochrome 450 enzyme, which is varied in this thing, because of which the drug metabolites increase and sometimes become more. They affect them more in these particular groups. Similarly, there is some genetic variation also. They have even gone to more genetic, some HLA alleles. This is all, of course, theoretical, but these various genetic alleles they have traced, and they have found that is a statistically significant in Japanese. Similarly, in Koreans, they have found and higher levels of NSAIDs induced interstitial fibrosis. African Americans, Negroes or African American, whatever you want to call them, there is a higher chances of, just like sarcoid is more in them, interstitial lung disease or restrictive lung disease. They have found this. So ethnicity, along with the socio-economic status and environmental, all could be faltering, but ethnicity is important, and especially this particular group, and we should be aware of that.
Wonderful. Beautifully put, sir. Dr. Beauty, I come back to you again and then I'll again come back to Dr. Tridib for the next question. These are very similar questions, but I think they are little different in a way also. So, Dr. Beauty, the question to you is try and elaborate on the diagnostic criteria for a daily clinical practice related to drug-induced lung injury.
So, to diagnose drug-induced lung injury, basically we need high index of suspicion, and particularly
So exposure has to be there, obviously. Yeah.
When patient presented with the new or worsening respiratory symptoms such as cough, wheezing, chest tightness, dyspnea, etc., we need to take proper history, including if there is any relevant exposure to include any drugs, if any drugs exposure history is present, then we need to assess the onset of the symptoms along with the starting of the exposure. That is very important, because to establish the temporal relationship between the starting of the drug along with the onset of symptoms. That is very important. And parallelly, we need to assess the other risk factors which Dr. Anil has already described. So we need to identify those risk factors also. And after that, we have basically the drug-induced lung injury is the diagnosis of exclusion. So we need to exclude the other causes of this presentation, like infections, any other exacerbation of underlying any lung conditions or any malignancy, etc., by relevant tests like blood test. We need to do the imaging also through X-ray, HSCT, to identify the pattern specifically, which type of involvement is there. Then basically, as I already discussed in my talk, that Fleischner Society also simplified the criteria if the patient presented with new opacities, and we will be able to establish the temporal link between the starting of the drug exposure and onset of the symptoms, and along with if we able to exclude the other possible causes of this kinds of picture, then probably we can conclude that this is a picture of drug-induced lung injury. But besides that, we need to do the relevant test, which we every one of us will do in our practice in a pulmonary function test to look for the gas exchange abnormality and all, etc. But the role of bronchoalveolar lavage basically to only rule out the infection or malignancy or any type of diffuse alveolar hemorrhage or any other disease. And here the role of lung biopsy is very restricted or limited, I can say.
Absolutely. Dr. Tridib sir, I come to you again, and though I know, this is more like a refutation, but I think it's worth it, because are there any particular sort of steps?
Yeah, so I will take it on from what she has said. I don't want just to repeat everything. So that is the first thing, is a high index of suspicion. You must know which drugs cause what, and keep it in mind. It must be in your mind, and then you try to temporarily see how person has taken that drug. Then in what circumstances? For example, I'll give you an example. Patient has been radiated and then subsequently has given an anti-cancer drug. So that's the patient who might develop a drug toxicity. Patient is in high levels of oxygen for a long time in the ICU, and because of his lung condition, and then he is given an AKT drug. So not AKT, some anti-cancer drug. So these kind of patients are likely to develop drug reaction because he is being exposed to a risk factor like an oxygen for a long time, and some, or he has an ILA. His earlier CT scan shows just interstitial lung abnormalities, and then they have found this that people with ILAs, they tend to develop lung DLIDs much more, interstitial. So these are the things which you have to keep in mind. I'm just telling in addition to what she's told, because she's covered it very nicely. Then the CT scan patterns, which the 6 or 7 patterns which she has covered, the interstitial pattern, those patterns you must keep in mind. Go into the detailed history. Rule out all other causes, which, like she has told, certain blood tests, yes, but they are not specific. KL6 levels, eosinophil levels, these are not specific. They can be, but if you rule out everything, then it can be. Then, while checking literature, I just found there are 2 other tests. I don't know whether they are done in India. Maybe pharmacologist will able to tell us. One is a leukocyte stimulation test, and one is leukocyte migration test. Now, what is it in brief? Whatever I could understand is, here it is: the blood is taken from the patient. It is not done in vivo; it's in vitro. It is the blood is taken out in the leukocyte stimulation test, DLST. It is taken out. The lymphocytes are isolated and they're exposed to the drug which you are suspecting, and they see if the lymphocytes proliferate and they activate and get proliferated by measuring radioactive thymidine and release of cytokines. If that happens significantly,
it's kind of a in vitro proof of what is happening in.
So in fact, in Japan, sometimes when they have to give this Jeptinism, they already check it before and then they give.
Before doing it, yes.
Before there are articles to that. Similarly, there is the leukocyte. That was lymphocyte. This is leukocyte migration, where same thing, blood is taken and the drug is added, and the leukocyte migration movement is checked by some, as far I did not understand, by some technique, and then they can say that yes, with fairly good amount of they can say, like we do bronchial provocation test for asthma and all that. So something like that here, but that is in vivo, here it is in vitro. So this, I don't know whether it's done in India or anywhere, but they are mentioned as part of, if you are suspecting, they can be part of the one aspect of the diagnosis of an DLID. Not by itself, but part of everything, along with MDD, along with the
whole clinical story has to be there, and then you add those.
I don't know what is done here. Maybe Subhankar sir, maybe knowing can.
No. I think Doctor, I'm going to go back to Dr. Dubey on this question, and sir, which blood tests are the most particular use in establishing a suspected drug-induced?
So, as Dr. Chatterji sir has already told, that no specific markers have been identified as yet, but we usually that it is the diagnosis of exclusion, so we need to exclude the infections basically. So we usually in our day-to-day practice we do the CRP levels, ESR, LDH, etc. Even we want to look at the cellular profile also. This also giving us a clue through whether it is neutrophilic inflammation, lymphocytic or eosinophilic. Though in some cases we found that eosinophil levels are increased in case of eosinophilic pneumonia, but not in all cases basically. And that surfactant protein A and D, that is also has a increased ratio in interstitial pneumonias, but mostly this is seen with mixed methotrexate related pneumonitis, but also it has not that much sensitivity reported, not that much specific, I can say. Even the KL6 also, they have some studies show that these are elevated in amiodarone-induced pneumonitis, but overall sensitivity is 89% they described. So not very specific as such. And drug lymphocyte stimulation test, sir has already described, so we don't know the utility as of now. It is whether it is available in India or not, but it needs.
Is it? I mean, is somebody doing this? I mean, in Indian settings? I mean, anybody in to my knowledge, I haven't seen it being
So,
done.
sir,
Sorry.
because it has also false positive, false negative responses also, even in studies also they have described, so not even established its yield as such. And the emergence of
I think a very racial,
yes,
predominance. Like for example, DPB is so common in Japanese, so everybody is suspected to be DPB unless proved otherwise. So I think that kind of a thing. So I think possibly the Japanese are doing it all these kind of.
And
yes,
they
Uh,
yes,
have the technology, I think, to do
yes,
all this.
exactly.
So,
They are the epitome of ethnicity in
and
one way or the other.
interestingly, I mean, just little diverting this
Sure.
lymphocyte stimulation test. It is given that it is very useful for predicting allergic reaction to AKT drugs.
Hmm.
okay.
EHRZ. I mean, these
Oh.
drugs you can.
So you are going
It
to
is
complicate
apparently very.
the yes.
I don't
एक
know
तो
whether
पहले ही
you.
ड्रग इंड्यूस्ड है और उसके ऊपर और एक ड्रग ऐड
ये
कर
वो करते इफ पहले से देख ले भाई ये रिफेम्पिसिन से नहीं है, दे सकते हैं इसको. I just it was
so
just
Dr. Anil
interesting, so
Kumar
I thought I'll tell.
Anil Kumar sir, this is a question for you. How important, I think we have already underlined the the importance, but at the same time, concurrent infections, how important it is ruling out, and how will you do it?
Sir,
If I'm seeing
basically,
shadows or
uh,
a drug-induced possible
yes,
toxicity kind.
sir, basically it is very, very important to differentiate drug-induced lung injury and a lung infection because both of them can occur concurrently. In this age of using a lot of neoplastic drugs, the drugs per se can cause a lot of infections because of that immunosuppressive effect, sir. So
Absolutely.
the thing is we have to first look into the overlaps in the symptoms. We have to certainly look into the fever, the cough, the shortness of breath, fever and fatigue. Everything can be because of either a concurrent infection or it can be because of the primary drug-induced lung injury itself, sir. In that scenario, to differentiate between the concurrent infection, we need to get the proper blood picture, we need to get proper imaging techniques, and in the blood we have to look for the specific neutrophils. If the neutrophils are predominant, let me say, then it's more of an infective nature. If the eosinophils are predominant, then we have to look into the drug-induced toxicity part. So certainly, the treatment implications are quite large here because if the infection is there, sometimes you need to discontinue that offending drug. You need to discontinue that, and sometimes pneumocystis infection can be there. Some atypical bugs can cause common infections. So we need to first do a complete blood picture, look into the CRP, see whether it is an infective cause or a non-infective cause. If it is a non-infective cause, then discontinue the drug and see. And if it is proven that it is an infection, first we need to treat the primary infection. Here, early diagnosis is very, very important, sir. Otherwise, we may end up going into a severe immunosuppression causing more infections, or we may end up taking out the drug and which can increase that the disease process. So we have to rule out concurrent infections in a case of drug-induced lung injuries.
Absolutely. And so beautifully said. I think ruling out an infection makes it $1 million decision-making process for a particular infection. If it is there, we have to treat it, and if it is not there, we need not. I mean, I'm just quoting an example from the recent bronchoscopy I did, and said, I mean, the patient was referred to me for a suspected mucormycosis. Very frankly, I mean, nothing to do with this whole story. Suspected mucormycosis in the right middle and lower lobe, right intermediate bronchus. And then we said the patient was put on suspected mucormycosis on isoconazole. And then the patient is getting referred to me for saying, can I excoriate that particular area and make it little more amenable to isoconazole? I mean, that's the whole story which came to me. And then we said, but where is the proof of mucormycosis? There was no proof of mucormycosis. And then we said, there was no proof of mucormycosis, so let's at least biopsy what is, say, visible. So because it was bleeding on touch, it was not biopsied by the peripheral doctor. So, well, I mean, and at the end of it, what we did was we said, let's do a bronchoscopy, find out. Yes, there was a mass there which was already visible in the bronchoscopy. We had a video of that also. So that mass lesion we biopsied. And the very second day, I get a call saying that the whole bloody sample that you have sent is mucor. Now, now the whole story completely changes and now takes of course, we had pre-counseled the patient saying that the upper lobe is spared, so maybe we might get away with a right middle and lower lobectomy, but we are not going to excoriate this whole damn thing and try and get some kind of little extra bleeding or maybe a death, one way or the other. But it's not really going to sort the problem out unless until my drug is in 100% sure to cure the entire mucormycosis. So I think a concurrent infection is important. Of course, this is not in the context of drug-induced lung injury, sorry, but at the same time, getting the proof makes a difference, and getting a, of course, I probably have answered part of the questions which are reserved for me. So I think I'll come back to imaging patterns, and I think that is important. Dr. Beauty, you have already beautifully showed all the imaging patterns. But at the same time, if you have any other additional comments on that, on drug-induced lung injury and whatever you have to say, please.
So, mostly the patterns we have seen in CT scan, there's an interstitial involvement. Either it may be in the form of hypersensitivity pneumonitis or diffuse alveolar damage or NSIP pattern or interstitial pneumonitis only. Sometimes it presented with more diffuse involvement, then it may mimic like diffuse alveolar hemorrhage like pattern also. And the popular agents causing any of them actually, like amiodarone, which I already discussed that it may presented with GGO, subacute ILD, or any of the other pattern, organizing pneumonia, etc. Then it confusing us basically. Actually what is happening and all. So besides the usual involvement, we should keep in mind that pleural involvement along with pleuritis and pleural effusion can be a cause of many drugs or side effects, but like prokenamide, etc., or different types of statins even, which are this can cause rarely, but they are the cause of this kind of pleural effusion. Besides that, methotrexate, etc., and even sarcoid-like granulomatosis also they can be presented, like where we found on histopathology only the granulomatous inflammation. We have started steroid and it responded, but usually it recurs because the offending agent is continuing actually. So we should keep in mind these types of abnormality also.
Beautifully said. I think, see, I as I see it, the whole story is never 100%, black or white. And I'm sure you all have said 50 shades of gray. So, 50 shades of gray is what is the story, whole story is about. Well, I mean, you have to be vigilant, you have to be suspicious, and you have to be careful. One way or the other, you can go wrong. And, I think one has to keep your antenna sharp one way or the other, that, okay, this is what I'm expecting and this is what I'm getting. And this is what I'm not expecting. So I think one way or the other, people have to sort of, sort it out in your mind before making up your mind on whether this is related to the drug-induced injury or not. So, Dr. Subhankar sir, you wanted to say something?
Yes, sir. Am I audible, sir?
Yes, absolutely.
Yes, sir. Sir, kindly repeat the question, sir. Kindly repeat the question.
I did not have one question. We had a barrage of questions. So I think, but I think the last one we were dealing with was imaging patterns, ruling out concurrent infections, and blood tests. These three were the last questions.
I just want to add something, sir.
Sure.
Sir, something it is possible that there are definitive evidences that we can declare that that specific suspected adverse drug-induced lung injury may be due to this drug or that drug, and the list is very tiny. I can say this is very tiny list where we can definitely say that the offender is that drug, like bleomycin, amiodarone. Honorable Tridib sir has mentioned nitrofurantoin. We have sulfasalazine, etc., etc. But as there are some special movements when we can definitely say that this is a drug-induced lung injury. The classical example is DLE, drug-induced lupus erythematosus.
Yes, absolutely.
सुनने में बहुत भारी भरकम चीज है, बट एक्चुअली आराम से डिफरेंशिएट हो जाता है जब हम लोग कॉजलिटी असेसमेंट करता है. इट इज वेरी इजी टू डिफरेंशिएट DLE. In SLE, we have malar rash, discoid rash, pancytopenia, kidney involvement. All body parts is being involved. And the ratio is 9:1, female to male ratio. In cases of DLE, आपके सामने हर चीज परोसा जाता है एक टाइप से. Male female ratio 1:1, number one. Minimal or rare kidney involvement, no malar rash, no discoid rash, pancytopenia, very difficult to diagnose. Hemoglobin 12 है, आप उसको एनीमिया भी बोलेंगे तो बहुत मुश्किल से. But the special thing is that we have specific pleuritis and interstitial pneumonia in cases of offender drugs. If this is DLE. No other system is involved. Only and most probably lung and pleura is involved. And the offenders are the drugs which are getting metabolized by acetylation. Sulfasalazine is one of them. Hydralazine, the antihypertensive drug, procainamide, diisopyramide, and in fact, gresofulvin also.
Dr. Subhankar, have you seen isoniazid also causing this?
Yeah, isoniazid. Yeah, sorry, extremely sorry, sir. I have forgotten this.
That does cause so many. In fact,
sir, he's the
also.
Actually,
Yeah,
he's
because
I forgot the king. I forgot the king.
India
I forgot the king. This is one of the, yes, this is also metabolized by acetylation, and this acetylated compound are strictly responsible, sir. And we can easily diagnose. We can definitely say we don't need histopathology. We can say this is a certain case or confirmed case of amuk drug-induced amuk lung injury. Jo bhi hai, sir.
Yes.
But yes, sir.
You please go ahead. I'll ask after that.
But sir, challenges come when there are some. One event I will like to share. Rheumatoid arthritis ka patient tha, and she was on methotrexate in very low dose. Okay. Suddenly, patches were there, and we made diagnosis that is methotrexate-induced pneumonitis. After that, few X-rays and CT scan finding, it was the immune suppression produced by methotrexate in that lowest dose, and there was infection of pneumocystis xeropsy or Carinae, jo bhi bole. So this is a misdiagnosis because this is not the cytotoxic dose of methotrexate. That is just immunomodulating dose.
Beautifully underlined the importance of
yes. This is very difficult to segregate. Now, after that, what we left at that case, we were wrong. We wrongly diagnosed as a case of methotrexate-induced lung injury, and it was pneumocystis infection. Now, one thing what we can help in such situation, that whether that is secondary infection or this is due to drug injury, is, as sir already mentioned, the count, the blood count. It may be helpful because in drug-induced assault, methotrexate-induced assault, at that case, we may get a normal blood picture and we may get patches or bronchoalveolar findings. हो सके तो हमको pneumocystis का cyst या कुछ ना मिले उसमें. Otherwise, it is very difficult. Another example is sarcoidosis. We are treating with interferon. New lesions are coming up. How we can say this is due to sarcoidosis or this is due to interferon-induced new lung lesions? This is very difficult. This is the 50 shades of grey part, as you have mentioned, sir. Here, हम लोग बेबस है. यहाँ पे we have to withdraw the drug If it is not a permanent injury, we will get decrease in symptoms. And if it is an irreversible assault, we can't say anything. Conclusion में पहुंचना बहुत मुश्किल है.
Absolutely, absolutely. But of course, I mean, knowing it too late is very painful and very sad. But at the same time, well, I mean, once in a while we do reach that kind of a situation where the patient is just brought to us with the situation where it is irreversible and you can't do much about it.
Nitin, just wanted to
Yes,
add
yes.
something interesting, especially when talk with अभी आपने Subhankar sir ने बोला.
Yeah.
So in one of the things in diagnosing, they have also mentioned is you can re-challenge that you can add the drug again, and of course there is a lot of इसमें ethical issue etc. है. But I want to know, suppose patient has got TB and isoniazid is one of the kind of pillar, as you said, king. तो उसको अगर आपने लगा कि yes, this he has developed drug-induced nephritis और कुछ खास नहीं है, just a mild symptom, would you such cases or that stage 1 Dr. Beauty ka, the asymptomatic picked up on X-ray or something only, not much, such patients would you like to try again? I mean, I am asking this. It's open for.
I think if you really see in tuberculosis, we do drug re-challenging.
Auto re-challenge.
Say that, okay, except maybe pyrazinamide, we do possibly reintroduce almost every possible drug, including rifampicin, isoniazid. We introduce gradually, but at the same time
But I am specifically asking for drug-induced. You are doing. Maybe you're talking about jaundice or
yeah. So drug-induced lung injury, it's extremely difficult unless until you reach a total remission. And for reaching a total remission for say a tuberculosis-like scenario is almost impossible.
Sir,
So it's not, so say for example, if I'm on say I am suspecting a methotrexate lung, I haven't, and in fact I'll ask myself that question, that how am I going to document a methotrexate lung? Very difficult. Once again, a biopsy is non-specific. Transbronchial lung biopsy is not really conclusive. BAL is not really going to be helpful. The BAL and TBLP are specific to only certain patterns, and they do not link a particular drug to a particular injury. They tell you the pattern at the most. So very rarely you can really, for example, if suppose I'm on a very specific MAB, which is specific to a cancer, and I'm seeing new shadows which are not cancerous, and I'm biopsying that, and I get a typical lymphocytic proliferation. Wonderful, great. I get a lymphocytosis, great. But at the same time, one more time, again, we have to reiterate that we have to also rule out concurrent lung infections, and B, make sure that there is no other drug which is likely to be causing this process. And I think so. The question is very difficult to answer, sir. Dr. Subhankar, you have.
Sir, I just want to answer Honorable Tridib, sir. Sir, actually what happens that whenever such type of situation comes that there is a milder injury and you have to continue AKT, we have to continue, sir. But at the same time, we have to monitor renal function test or any test related to the function of that organ. We have to monitor, sir. We cannot completely stop. But after reducing the dose and monitoring the function test, still the disease is in progressive mode, then we have to de-challenge the drug. This is number one. In case of lung injury, sir, if the patient is maintaining more than 90% saturation and some sort of obesities are there, and we are suspecting the offender drug may can cause this type of scene, we can continue the drug. If it is life-saving or improving the disease process, when there only the adverse effect is mild or milder. If he is having problem in climbing stairs, पाल्टी लेके दो स्टेप चले कि नहीं सांस फूलना शुरू हो गया, तो उस कंडीशन में जो है वी हैव टू कंसीडर have an X-ray or CT scan, see the progression, then we have to withdraw. But otherwise, in milder cases, sir, we can continue, sir.
Yeah, wonderful.
Okay,
Beautiful.
Like in cases of, like one example, sir, we often see, sir, in HIV people living with HIV AIDS, we used to give antiretroviral drugs, zidovudine. If you are administering, a normocytic normochromic anemia will be there, persistent, but we have to continue
yeah.
because in hemoglobin 9 he can manage all his daily activities.
Absolutely. Absolutely. Very well put, sir. So I think I'll come back to Dr. Anil Kumar, sir, on the issue of drug-induced pulmonary edemas. I mean, stories, wisdom, patterns, anything. I mean, commonly seen.
So generally, by definition, it is a condition in which there is a buildup of fluid in the lung tissues. That it can be because of reaction to the medication, or I would say two mechanisms rather. The fluid accumulation can be directly because of the drug acting on the heart itself. Then it could be a cardiogenic pulmonary edema, but most of the times drug-induced pulmonary edemas are of non-cardiac origins. That is what we are supposed to remember. And generally, there is many diverse mechanisms for this. And the most important would be a direct toxicity to the lung tissue as well as increased capillary leak, maybe a damage to the alveolar capillary membrane and alterations in the blood vessel permeability. Maybe these are the commonest causes for the non-cardiac pulmonary edemas. So drug-induced lung injury, the pulmonary edema generally is because of the leakage of the alveolar permeability membrane. So the fluid gets filled into that, and generally the symptoms would be shortness of breath, cough, once again chest discomfort, tachypnea, hypoxemia. All these things could be the symptoms. And when it comes to the medications which are the offending agents, generally nitrofurantoin, that's the biggest culprit. Then we have all the chemotherapy agents, the neoplastic agents like methotrexate is very common. And once again, the drugs used for the heart disorders itself, amiodarone once again can cause a very bad pulmonary edema. And the illicit drugs like heroin and the cocaine, all these can cause pulmonary edema. Sir. So we always have to look out for the non-cardiac cause of pulmonary edema, and we have to look out for this.
Absolutely. Dr. Beauty, I come to you on this very important juncture on the therapeutics, because we have so far discussed all patterns, this, that. So how would you approach therapeutics? Of course, taking the drug off is one of the most important first steps. But beyond that, mild, moderate, severe, how would you approach? I mean, pulsing, not pulsing, giving steroids, what dose, and what's your approach?
So basically, the timing is important, as I already discussed. If the patient presented early with the onset of symptoms and between the time of starting of the drug, then might be it is in the early stage or reversible stage. We need to confirm it through imaging. If the imaging CT patterns shows presence of ground glassing or consolidation, but very less amount of reticulation, then probably the patient belongs to the reversible stage only. Then we need to consider steroid after ruling out the infection, as I already told. And in that case, if the patient is in the moderate to severe stage, that means either requiring hospitalization, oxygen or other supports, then too we need to consider as a high dose steroid. Even pulsing may be necessary, because there is a significant chance of reversibility in that patient, in those patients, along with the supportive treatment, the already important one, empirical antibiotics, oxygen, other measures.
Absolutely.
But if the patient
and the dosing, would you go all out for, say, a pulse dosing of methylprednisolone, or give moderate,
usually, sir, moderate dose is good, because otherwise we again invite chance of infection,
and
and
then
in that
you have
case
another
again,
headache on your hand.
it is a double-edged
Unless
sword.
if you are in a life-threatening situation, you wouldn't pulse somebody, isn't it?
Yes,
Yeah.
yes.
And that too with possibly an adequate antibiotic cover and a very careful evaluation for secondary concurrent infections. Definitely. thing.
Yes, sir. Like, sir, I just want to tell that methotrexate induced drug-induced lung injury, if presented in the early stage, mostly it is reversible because at that time fibrosis does not occur significantly if presented within weeks of exposure. But if it presented after months of exposure, then probably there is extensive fibrosis in those patients. Usually they become steroid non-responsive. So practically we don't left with any options
But to
actually.
give maybe add antifibrotics and hope for the best. That
Yes,
is,
yes, sir.
or go for a eventual lung transplant.
Or lung
Nitin,
transplant. Yes, sir.
just a
Yeah.
message from Dr. Krishna that we have almost 1500 logins.
Wow, wonderful,
Nearly,
fantabulous,
little less.
great. For
Thank you.
this kind of a topic, 1,500 people, I'm surprised and I'm touched. Very great.
Yeah, I think everybody wants to learn. I mean, we have also learned while preparing for this. I mean,
I am continuously learning. Let me tell you that every
this
minute
is
I'm listening to something very valuable.
this is something
Dr.
which is
Subhankar,
good.
we come to you because I mean, all of us are clinicians and we're the only pharmacologists. So about pharmacovigilance and even the preventive concept of, how can we prevent DIL, drug-induced lung injury, or DILD, drug-induced lung damage, whatever you want to call it.
Okay, sir. The most challenging part and for making a causality assessment, that is
Yeah.
whether this offender is responsible for particular lung injury. I will not take much more time, just in few points. There are seven things or seven parameters I want to discuss. And very short. First one, evidence that we are getting a case of suspected drug-induced lung injury from a suspected drug. Is there such evidence in our whole database? PubMed se leke sara database हमने खंगाल लिया and we had got such evidence. So this is first point, positive. Second, temporal association. Temporal association means the adverse lung injury or the drug-induced lung injury after introduction of the drug, there is a period. As for microorganisms, we have incubation period. Here, the pathogenesis period is a particular pathogenesis period is there, and after that we are getting symptoms or pathological changes. So this is temporal association. That is the drug, the offender, and after introduction of the offender, we are getting a symptoms. There is a time lag. So if temporal association is present, now here is another challenge. हमने कोई ड्रग एडमिनिस्टर किया, सिम्टम 1 महीने बाद आने लगा, तो 1 महीने तक उसका पैथोजेनेसिस में टाइम लग गया. इन सच सिचुएशन टेम्पोरल एसोसिएशन को डिपिक्ट करना भी बहुत मुश्किल हो जाता है. बट वेरी रेयरेस्ट ऑफ रेयरेस्ट केसेस में कोई ड्रग इतना टाइम लेता है. मैक्सिमम ड्रग्स का पैथोजेनेसिस 14 से 21 दिन के बीच में मैनिफेस्ट हो जाते हैं. सो दिस इज द सेकंड पॉइंट, टेम्पोरल एसोसिएशन. थर्ड, द मोस्ट इंपॉर्टेंट, डी चैलेंज. द ड्रग इज द चैलेंज, वी हैव विथड्रॉन द चैलेंज and there is improvement of symptoms. We can say it positive D challenge. Third one. Fourth, the most important again, re-challenge, reintroduction and the same symptoms. Ethically, 99% cases में possible नहीं है, क्योंकि milder मतलब अगर हम lung के बात बोले, in only milder cases, mild to milder cases, we can reintroduce the drug. Will not take risk for a diffuse alveolar damage or splitting of pulmonary vessels. We can't take such big risks. So re-challenge is, if we can do with all our ICU and other setups, we can do it in mild injuries only. This is the fourth point. Fifth point, the very crucial, is there any evidence of pre-existing lung disease and we have administered certain drug and we are suspecting certain drug-induced lung disease? That is an overlap. If there is no some such pre-existing lung disease, then we can say the offender drug is, we are nearby to say that this offender drug has done this assault. But if there is pre-existing lung disease already present, like I have discussed, rheumatoid arthritis is there, we have introduced methotrexate, there is pulmonary infiltrate, who knows, it is due to methotrexate or reactivation of rheumatoid part in lung. We don't know. So this is the fifth point. Sixth point, serum biomarkers. If there is liver injury, we can get enzymes deranged. If there is lung injury, we can get FEV1, FVC, and all this spirometry and other related parameters. You people know better. And last one is histopathology. So if any drug-induced lung injury is there and all 7 points are fulfilling with this, like there is evidence in database, temporal association, that is time plausibility, de-challenge positive, re-challenge positive, matlab de-challenge we have done re-challenge, conditions were there, re-challenge is also positive, serum biomarkers are with the drug, histopathology is also positive, then we will say this is the definite evidence that such ADR has been like pneumonitis caused by amiodarone, some drug causing this, we can that definitely say this is a definite association. What happens? Histopathology, ethically not possible. Patient often doesn't get consent or we found difficult for fragile patients. Second one, re-challenge. If possible, re-challenge. Forget we are not getting any histopathology. But if re-challenge is possible, then we will say the association is definite or certain. Because this is one evidence we can say that reintroduction has caused the drug. Though we have no biopsy report. Even serum biomarkers is not available. But if re-challenge is positive, we will certify the case as certain association of the drug. Second, re-challenge is not possible. Histopathology is not there. Biomarkers also, the patient has some financial issue. He cannot do all the investigations. Okay. What we have? Number one, evidence, database, temporal association. Second, third one, de-challenge. This is positive here. De-challenge is positive. Discontinued the drug, symptoms are improving. Fourth one, no pre-existing lung disease is there. Still, we are in favor. This is a probable case of this drug. This is the probable drug-induced that disease. But we can't say it definite. The term has been changed to probable. Causality association is decreasing.
Yes.
Last one, the very important. There is pre-existing lung disease present. Histopathology not possible. Biomarkers not possible. And pre-existing lung disease is there. So causality assessment is getting little down. We'll say the association is possible.
Plausible, yes.
Possible.
Yes.
And the last one, de-challenge is not also negative. We have withdrawn the drug and we are not getting any improvement. Then we can say this is unlikely.
Unlikely.
But here is also a question. If the injury is irreversible, the drug-induced lung injury is irreversible, after discontinuation of the drug, we cannot see any positive improvement. So being de-challenge negative, we can't say that there is no association.
Absolutely. Absolutely.
Okay.
It depends on your index of suspicion.
Yes. This thing. Yes. This thing. So these are certain parameters through which we can go through the causality assessment part of drug-induced injury to any organ anywhere. Nowadays, a very important terminology is there, which is known as SUSAR. SUSAR. Suspected, unexpected, serious adverse reaction. मीन्स सस्पेक्टेड है, अनएक्सपेक्टेड इसलिए क्योंकि डाटाबेस में आज तक वर्ल्ड में कहीं भी ऐसा एडीआर रिपोर्टेड नहीं है, बट सीरियस है, सस्पेक्टेड है, अनएक्सपेक्टेड है, सीरियस है। और ये सबसे ज्यादा देखा जाता है टायरोसिन काइनेज इनहिबिटर्स जो अभी नए नए इंट्रोड्यूस हुए हैं। फेज 4 ट्रायल अभी बहुत जगह जो है ठीक से पूरा हुआ नहीं, लार्ज पॉपुलेशन को कवर किया नहीं, एंड वी आर गेटिंग न्यूअर लंग इंजुरीज from these drugs. So this is suspected but unexpected. पहले केस हो सकता है हम ही को मिले किसी को, बट हम इसको इग्नोर नहीं कर सकते। And the immune modulators, the Zumabs also. So in prevention part I can say ज्यादा कुछ नहीं बोल पाएंगे, यही बोलेंगे कि टाइप ए एडवर्स ड्रग रिएक्शन हमारे हाथ में है, बट बिजार रिएक्शंस जितने भी है, जैसे ब्यूटी मैडम ने बोले हैं, अनिल सर ने बोले हैं कि पहले आपने डायग्नोज कर लिया इन अर्ली स्टेजेस, only reversibility is there. एंड मैक्सिमम केसेस में देखा गया है अगर इरिवर्सिबल इंजुरी नहीं है, ड्रग का डिसकंटिन्यूएशन से भले ही 15 दिन लगे, 1 महीना लगे, द सिम्टम्स विल गेट इम्प्रूव. दैट्स आई कैन से. थैंक यू.
Wonderfully. Great.
Nitin, just one small point
Yes.
in
Sure, sure.
continuation with what he has said is
Absolutely.
I just remembered, I read it, because people are nowadays, cardiologists are using Cardaron, Amiodarone quite a lot and for long periods of time. There are some people who say that in such little bit elderly people or somebody with some sort of risk factor, a serial lung function should be done. I mean, in his case, a scan was done. That was fantastic. But if you
Yeah.
cannot do a scan, at least
Lung
keep doing
function
a
test.
lung function and see if you have, there is a drop in FPC and all that, which is suddenly happened. 1 liter say it has come down to. Then it's time to do a scan.
Unexplainable.
So that is one point which I just remembered about, specifically with the amiodarone, which that sometimes is given for a very long time.
Yeah.
I have one point here, sir. Do a DLCO. If the DLCO is like low, try to avoid the pneumotoxic drugs. If this can be followed, maybe we can prevent that drug-induced lung injury.
Sir, actually, what?
But if you really ask me, there is a counter argument to it. Most of the people, for example, say an advanced lung cancer, one way or the other, may have a DLCO which is low, and the drug is the only option. And it may be a MAB which may by itself can cause a drug-induced lung injury. So I think this is going to be going round in circles. The point is well taken that somebody who is very, very compromised lung function, I wouldn't expose him to something which is lung toxic. Agreed. But that may not be realistic in many practical situations. One question Dr. Lakshmi Murli from Tamil Nadu, Tiruvallur has asked is on stoppage of the offending drug, the lung changes reverse to normal. How long will it take and then it stops? I mean, how long will it take for it to normalize? Any one of you can answer this, please.
It depends on what type of assault has been done. I have just reported 1 month back a case of DRESS, drug rash, eosinophilia, and systemic symptoms. DRESS by linezolid. MRSA infection was there, and linezolid 600 milligram twice daily was prescribed. Now, after development of DRESS, when supportive measures were given, though after that it took 4 to 5 weeks to get rid of all the symptoms. So I can say that this was a very bizarre reaction, but you can say the pathogenicity and the severity of the ADR will decide कि कितना time लगेगा उसको revert होके normal आने में.
Yeah, so I would give largely put say 6 weeks is a realistic figure, and then anything maybe from 6 to 12 weeks maximum. Generally, something which is not settling in 12 weeks, I think the damage may be irreversible. That's that's the way I look at it. I mean, so that's sounds realistic. Mostly, not in all cases, mostly. We have seen miraculous recoveries happening over a period of 1 year in many situations. So that's accepted. But at the same time, I think something which is not settling in 12 weeks, I would rather say maybe it is not that reversible. I thank you, each one of you. But before I thank you, I want your last remarks. And I'm starting with the senior most, which is Tridib sir. So your last remarks, and then whoever thinks is the youngest or little lesser, younger than him can take the next, and in that order. And I'm of course only 18-year-old, so I'll have the concluding remarks. So Tridib sir, you are on a mute.
This is most important is you should have an index of suspicion. If something new comes up on the drug which is known in literature to have caused this, and you can't easily explain it, but you must keep in mind and actually then maybe work up thinking, trying to rule out everything else and trying to have a multidisciplinary approach to it. It is not something which you can do on your own. That is what I would like to stress. You have to talk to radiologists, talk to the pharmacologist, talk to the microbiologist, talk to your other colleagues, maybe in a group, our CCI
very
group.
frankly, sir, today we are having a pharmacologist amongst us to talk
Yeah,
and
I mean,
give
I think he has
done
given
such a
us the
wonderful
maximum
job.
output.
So,
I
hats
really
off to Dr.
congratulate.
Subhankar, sir. Yeah.
Subhankar, you have given us the best output. I have actually noted down your 7 points. I have noted it down here.
Oh, my pleasure.
So that's it. Basically, keeping an index of suspicion and then working towards it. That's all. I don't want to add anything more. Please go ahead.
Yeah. I think who looks the, I mean, I don't want to. So, okay, Dr. Anil Kumar, he's
Yeah. So my take home point would be vigilant, as Tridib sir said, be vigilant. Even a simple, trivial, normal drug can cause a drug-induced lung injury. So as we know, INH we have been using for ages is the biggest taking and offending agent. So I would tell everyone to be vigilant. If you have any doubt, just go into the literature and check into the drug registers that it causes a drug reaction or not. That's it. Just check it out and then do it.
Yeah. Dr. Subhankar, sir, once again.
आई जस्ट वांट टू कोट त्रिदीप सर, जो सर पहले बोले थे कि आज के डेट में सबसे बड़ा चैलेंज, द बिगेस्ट चैलेंजेस इज दैट elderly patients are using herbal products immensely. Herbal products, or I don't want to take any company's name, हमको जेल नहीं जाना है.
But then they're crazy.
हाँ, very much crazy. And who knows which molecule is enzyme inducer and which molecule is enzyme inhibitor? We don't know. And these pharmacokinetic interactions are mostly responsible for either production of a toxic metabolite or not detoxifying the toxic drug. So that's why I just want to say that such type of irrational use of herbal products, there should be a biggest pause.
May I add, even not herbal products, we had a recently celebrity death who was taking some 8-9 types of so-called youth medicines and vitamins.
Yes.
This is very dangerous. So anyway, this is should not happen.
Sorry, my net connection is not very stable right now. Sorry. Yeah.
Dr. Beauty, you can add
Dr. Beauty, your comments on this?
My take home points is we should try to identify it early as possible, because in the early phase, so it still remains the reversible. So we have treatment options, and if we don't have any index of suspicion and we don't do the multidisciplinary discussion, then we will be unable to identify it early. So if we are not doing this, then we probably have left with nothing, no treatment basically. So
you are not audible, sir.
Nitin sir, mute.
I am back again. Sorry. my internet somehow threw a fit. There are a lot of rains in Pune, unusual amount. Sorry.
Here also.
Yeah.
I think everybody is given their. Nitin, you can sum up. I think maybe.
Yeah, I think I'll sum up saying that this is one very, very important aspect of our day-to-day therapy issue, because we are prescribing a drug. We are in way linked to that drug being prescribed. We are not 100% legally liable to everything that happens to the patient, but we have a job and responsibility to explain to the patient that there are possible problems which will happen. And these need to be explained to the patient in advance if you know of them. If you don't know of them, you have to be frank and candid if the person comes up back with a response which is not expected, and you suspect this to be because of this drug. I would rather be open and very frank about it, that maybe I have not seen this. I have not seen the kind of reports, but let us re-explore this whole thing and be very pragmatic about it. And what Dr. Subhankar was saying was de-challenging, and de-challenging is the most sensible thing. I mean, it is one of the most easiest thing in the world to practice. rather than say doing a bronchoscopic lavage or a transbronchial lung biopsy. So I think de-challenging is one of the most sensible things to do, and see what is happening around the clock. And we as pulmonologists, we have impulse oscillometry, we have, I mean, if airway obstruction is documented, or we have a lung function which will tell us over a period of time. So one way or the other, we can make sense into what is being said. So I think with that, I conclude today's talk saying that drug-induced lung injury is an important subset of our practice, shouldn't be ignored, shouldn't be overhyped either. At the same time, I don't want my patient to become phobic, saying that every single drug I'm saying is going to cause some serious toxicity. No, not at all. But if something important is coming back as a feedback, I wouldn't ignore it either. So both ways, I would be rather open, at the same time rather reassuring. So both components have to be taken into consideration. And as Tridib sir very beautifully said, you have to talk to your rheumatologist in interstitial lung disease. You have to talk to your radiologist in almost everything. You also have to talk to your pharmacologist. And Subhankar, great to have you today. It was wonderful having your experience in this, and beautiful. So I thank all my panelists, and I'll declare this to be closed. Thank you very much.
Thanks a
Thank you,
lot, sir.
everybody. And wonderful moderation, Nitin. I must commend you for taking this so nicely, informally.